Thank you for the kind introduction. So thank you for the organizers for the kind invitation. I'm very happy to be here. So I presented 2 years ago this study, and now I think we are better advanced. So this is really an update of this study. So I will talk to you about Voxel-Wise Recurrence prediction. So I think our task is a little bit difficult than others that were presented before, and we are in the context of radiotherapy treatment. And I would like to thank my colleagues who are in the room, Camilla Satragno and Anna Stan, who did a lot in this study. So the context, I think that you all know this context. So I will speak about glioblastoma patients. So glioblastoma is the most common malignant primary brain tumor, and you have these very famous numbers. So more than 50% of, it represents more than 50% of all malignant tumors of the CNS, and these figures are coming from the US. And you all know as well that the prognosis for this patient is quite poor. So the median overall survival, you have here some example coming, sorry, I will take that. So you have here some example coming from a multicentric study, 7 centers, more than 1,000 patients. And you can see here that the PFS is very low, just 8 months. And the OS as well is just about 17 months. So the standard of care for this patient, you have to know that there was no change in the therapeutic strategy signed 2005, where the STUP protocol was proposed, and you have here the standard of care for this patient. So it's maximal safe surgical resection. Then you have concurrent radiochemotherapy and next adjuvant chemotherapy. And you can here see the benefit of using this chemotherapy in addition to radiotherapy. And this was the very good results, the positive results of the STUP protocol. One other thing to know about this disease is really the importance of the extent of the resection on the overall survival. And here you have this illustration. So it's only cortical tumors, and you can see here the difference in the overall survival depending on the quality of the surgery. In that case, it's supramaximal resection, and here it's gross total resection, and you can clearly see the difference in terms of overall survival. So I'm working in radiotherapy, and I am a physicist, so it's my disclosure. I have to admit that. I think I'm the only who is not a doctor for this presentation. And so I will speak more about the technique of the radiotherapy planning. So regarding the treatment in radiotherapy, you have to know that this is this one-size-fits-all approach, meaning that for all the patients, the prescription is the same. So it's 60 gray in 30 fraction. And here you have some illustration of a radiotherapy plan. So you can see here that what we call the GTV, which is this red volume, correspond, based on the last recommendation, to the cavity plus the T1 contrast enhancement. And you can see that we treat not only this volume, but we extend this volume in order to obtain this blue volume that corresponds to the planning target volume. And in fact, we had these green margins. You can see that the last recommendation, these margins are isotropic margins of 15 millimeter. This is to take into account the microscopic dissemination. And after you have this 3 millimeter isotropic margin to take into account the difference in positioning of the patient on the accelerator for the radiotherapy treatment. So at the end, we arrived to this kind of volume of irradiation, but keep in mind that this is the same prescription, whatever the aggressivity of the tumor. And another point is that there was no change in the delineation guideline over the last 10 years. And as I said, so this is the rules to define the target volumes. And as you can see, these guidelines, they are discouraging the use of advanced MRI techniques in order to define these target volumes. The problem, and it has been already described before, is that the recurrence are observed in the majority of cases in the irradiation fields. So here you have some interesting numbers coming from a study on more than 300 patients. And you can see the recurrence pattern depending on the quality or the extension of the resection. If you have a subtotal resection, you can see that the patterns, they are more local recurrence. And if you go to supratotal resection, the patterns are a little bit different, but majority of the recurrence, they are still local. So we still do not know why are this recurrence, what are the reasons of this recurrence, why these tumors are so aggressive, but just keep in mind that there are a lot of researchers working on the study of the radioresistance of the tumor, and one origin can be the presence of tumor stem cells. So in the radiotherapy context, we are looking for some strategy in order to better treat this patient, and one solution could be the dose painting strategy. So what this strategy means, the goal is to change really the paradigm of the treatment, so stop this strategy of prescribing the same dose for all the patients in a homogeneous way, but on the contrary, go to personalized heterogeneous prescription. So the goal is quite simple at the end. Based on all the information we can collect, and it can be, for example, functional, molecular, imaging, and so on, the goal is to try to quantify the aggressivity of the tumor at the subregion scale, so it can be the Voxel scale, and the goal is to, at the end, adapt the prescription to this risk. So at the end, you will arrive to a prescription that can be subregion or voxel, at the subregion or the voxel scale. Just to say that some other groups have tried to make this dose painting irradiation strategy. This is a positive result from a phase 2 study that was done in the US, and they have shown that if they adapt the volume of prescription, and if they can escalate the dose depending on the F-dopa signal, they can improve, so this is the results here, they show that they can improve the PFS in MGMT and methylated glioblastoma. So in that study, they really escalate the dose depending on the F-dopa signal. Another trial, but in that case it was a negative trial, was done. This is the SpectroGlio trial that was proposed by the group of Toulouse in France. In that case, what they did is that they escalate the dose in some portions of the tumor in which this ratio, so this choline to NAA ratio, was high. But as you can see, so they included 180 patients, but as you can see, the results were quite negative, except a little bit of positive signal for methylated patients. So in that context, now I think it was 5 or 6 years ago, we decided to start this AI Dream project. So AI Dream is for artificial intelligence for diagnosis, review, and radiomix acceleration in medicine. So you can see here all the partners of this project. And our goal is really to change the paradigm. So keep in mind this wish of doing dose painting, but instead of analyzing only one functional or one molecular biomarker maps, the goal is to see what we can do by combining all this information together and try to implement AI inform dose painting strategy for glioblastoma patients. So in that aim, so the project is in 3 steps. So first we create a multicentric cohort. So you can see that the cohort gathers data from 3 French and 1 Italian center. It was, to be honest, quite a big work because we gathered data, so clinical, biological, therapy data from 975 patients. We managed to obtain as well the longitudinal images, MRI images, and we prioritized 2 time points. So the pre-radiotherapy time point, so it was post-surgery pre-radiotherapy, and the imaging at the time of the relapse. And the most complex task of the work was to annotate, in fact, all these data, this imaging data. And as I will present you after, we annotated all these data with 5 labels. So the tumor was really annotated with 5 sub-region labels. Next, based on that, we developed an automatic segmentation tool. And we are now at this stage of trying to develop a Voxel-Wise Recurrence prediction. So I remember you, this is at the post-surgery pre-radiotherapy stage in order to guide this dose painting. The first model we developed was only developed based on T1 with gadolinium and T2 flare. So it was just a tentative of prediction of relapse area based on anatomical imaging. It was not super good, so that's why we discussed with CERCARE in order to try to generate these new biomarker maps and see if we feed our prediction model with this kind of information, we can improve our relapse prediction at the voxel scale. So 2 years ago, I presented at this congress, and this was an interesting case I presented you so in 2024. And in fact, we opened a lot of cases randomly based on this AI Dream big cohort, and we saw at that stage that there was some very interesting signal. And this is an example. So it's a 64-year woman. So you can see the date of the diagnosis. There was a partial resection of the temporal lesion. At that stage, at that date, we don't have the MGMT tested, and the patient was treated with the Stub protocol. So radiotherapy, 60 grays plus temozolomide. You can see here the T1 with gadolinium injection. You have seen this very important hyper signal on the T1 with gadolinium image. You have here this quite strange signal, and here you have the corresponding T2 flare image. So this is pre-radiotherapy images. And you have here, so this moderate signal in the flare image. Based on the discussion we had with the radiologists, they said us that this is really tumoral, this is really the aggressive part of the tumor. For them, this hyper-intense flare signal was more like hemorrhagic post-surgical modification. And you have here the CBV, the CTH, the rCMRO₂, and here you have the relapse. Sorry, I didn't translate the word. And as you can see, the rCBV was very high signal. The CTH showed that this region can be aggressive. There is a signal, positive signal here. And as you can see, the relapse was here, and on the contrary, here the treatment was quite effective. So I said we opened a lot of cases, we had a look on a lot of cases. We find that there was some very interesting signal, meaning that it could be of interest for us for our task of trying to predict the recurrence at the voxel scale. And that's why, in fact, we continue our study and we try to arrive to more quantitative results. And we gathered, so based on this AI Dream cohort, we created a sub-cohort. This is the description of this sub-cohort. So 186 patients, so all are coming from our institution. You have here all the descriptions, so it's high-grade glioma, because at that time we don't have access to the IDH and MGAT, IDH status mainly, for all the patients. And as well with the goal, our goal, I will describe it to you just after, our goal was to try to find a threshold in order to say this portion of the tumor is the most aggressive, so the goal would be to escalate the dose in this subregion. So in order to validate our threshold, we as well tried to collect data from other centers. So you have here the two centers, so La Pitié-Salpêtrière in Paris and the Hospital of Genova in Italy. And you have here the number of patients we gathered for each validation cohort. You have here the metadata. So as you can see, we are not homogeneous at all regarding this acquisition parameter. And I will try to be brief on that figure, but as I said, our goal was to predict at the voxel scale where the tumor will relapse based on the pre-RT MRI. So in order to see the predictive information of all these CERCARE biomarker maps, what we did is that, so we retrieved the pre-RT images. As I said before, we annotated with 5 labels all that images. So the 5 labels were the necrosis, the edema, the enhancing signal, the surgical cavity, and the postoperative modifications. We generate as well the biomarker maps, and we did registration in order to put the relapse images in the same referential, in the same space. And our goal was to see the predictive value of these biomarker maps. So we computed IUC, as it was done before. We computed as well sensitivity and specificity. And for sensitivity and specificity, I will explain to you how we choose the threshold. So regarding what we consider as label 1, so positive voxels, was either the gadolinium uptake at relapse, so what we consider, what we want to really identify to predict are the gadolinium uptake at relapse. And another things we tried to predict was the new gadolinium enhancement, so signal that was not present at the pre-RT time. We did different studies. I will try to explain that to you. We evaluate the AUC values first at the patient level threshold, We took all the voxel in one patient and we evaluated the capacity or rCBV, CTH, OEF, and so on in being able to predict the relapse area. So we computed the ROC curve by changing progressively the threshold for these biomarkers. Then we thought that if we want to define a threshold that can have a clinical utility, in fact, we pulled all the voxels coming from all the patients together in order to define what we call a population threshold. like this, it can be used after by the radiation oncologist to define, to optimize the tumor, the target volumes. And this is only this population threshold that then we apply to our 2 external cohorts to validate the sensitivity and specificity for each patient. So here you have some example of annotations. So here are all the labels I mentioned before. And as I said, our goal was to evaluate the ability of the CERCAR maps to predict at the voxel scale the enhancing signal at the relapse or the new enhancing signal at the relapse. This is the parameters that we selected. We had a lot of discussion with the engineers, application engineers from CERCAR, and we arrived to this optimal parameters, but if someone have other advice for us, we are open to discussion. And this is just an illustrative case. So as I said before, I'm not a doctor, so I will try to describe it the best I can. So this is a male patient. It's a GTR, so gross total resection. You have here so the diagnosis, so it's a GBM patient, or a high-grade glioma patient, because the IDH was not tested. And here you have the, here it's to show you an idea of the difficulty of the task for the radiation oncologist. So it's pre-RT MRI, T1 with gadolinium, and it's different slices. And the objective for the radiation oncologist is to define the targets. So as I said before, the first step is to define what we call the GTV, so the surgical cavity plus enhancing signal. But as you can see, for example, on that slice, is that you have here the margin of the cavity, and it's not really evident to conclude where the tumor is still aggressive. And as we discussed with our colleague in the room, the more questioning part is here. So you have here the corresponding rCBV and rCMRO₂ maps. So here it's the surgical cavity, and as you can see, there was no detectable macrovascular signal. And here you have the corresponding CTH and OEF showing that this region, in fact here, can be really questioned. And normally, I think that the radiation oncologists, based on this information, would really have adapted their GTV plan, their GTV volume, and put that as aggressive and put that in the GTV. And you have here the relapse. So it's just to say that we are very positive regarding this CTH and OEF contribution, because you can see here that the relapse was mainly in that direction. So I will just now conclude by showing to you our quantitative results. So in the discovery cohort, as I said before, in the first step, we optimized the biomarker threshold for every patient. And you have here so the different results, so CTH compared to rCBV, so showing that even at the voxel scale, we have an interesting signal for the CTH, a little bit less for the OEF. And what was interesting is that based on this population level analysis, so in which we put together all the voxel of all the patients, and based on the Uden index, meaning that we would like to optimize the compromise between sensibility and specificity, we managed to define some cutoff. So you see, for example, for the CTH, the optimal threshold in order to be able to predict the recurrence. So the gadolinium uptake at the time of recurrence is really this value of 2.6, and I think it's in agreement with all the values I have seen before in the other presentation. Next, based on this population threshold, we compute the sensitivity and specificity value So we fixed the threshold, we applied the same threshold to all the patients, and we calculate these values, sensitivity and specificity values, and just to see that it's really interesting. It's not perfect. We had this in mind before starting the study, but it's quite informative and very much informative compared to the CBV. And we are now in the process of applying the same threshold on our 2 validation cohorts. So it was values that we obtained before. We have changed, in fact, the parameters in the rCBV software recently, so do not be worried about this value of threshold that are different from the one I presented before. But we are very positive, and we think that we will have some very generalizable results. So in conclusion, so we have established a large-scale, multicentric retrospective cohort of approximately 1,000 patients within this big multi-partner AI Dream project. We add in this big cohort pre-RT, post-operative perfusion imaging for a large number of patients in our institution that enabled us to make this initial discovery analysis. We managed to gather 2 independent test cohorts, but if some of you have other cohorts available at that stage, so the pre-radiotherapy stage, we would be very happy to collaborate with you. And we are now in the implementation of the rCBV medical neurosuite into our clinical routine, and our prospective evaluation is in progress. And we draft at that time as well a clinical trial protocol to evaluate this prospectively into at least centers. So I would like to thank all my colleagues, and in particular Camila, Mohamed, and Anna, who really work hard on this project. Thank you.
Thank you for these exciting data and amazing talk. Comments, questions from the audience?
Hi, thanks for that lovely talk. I'm curious why you didn't include DTI data as well, as there's already evidence out there that DTI can predict recurrence in GBM. Would that not strengthen your diffusion tractography?
Yeah, the tractography. In fact, now we have it in fact, in our protocol, the imaging were done in the radiology. We are working in the radiotherapy department, so we have not the possibility to adapt, in fact, the protocols. But now we have an MRI in our radiotherapy department since 1 year, and now we have implemented the DTI in order to better define the possible direction for the dissemination. Right.
Yeah, thank you.